is before, when the period of gestation is less than 37 week. 37 complete week is term, and less than 37 week is preterm. 37 to 40 weeks, it is called as term. After 40 week we say post-datism, and post-term is more than 42 weeks. Very good, very nice. Most of you have said rightly. So let's go ahead with the definition of the preterm is the delivery before 37 weeks of complete gestation. Now, why it is important to understand why we are so worried about preterm labor? Because it is a major cause of neonatal morbidity and the mortality. There are various things which are seen specifically in the preterm babies. These are remember these 3-4 things: respiratory distress syndrome, necrotizing enterocolitis, intraventricular hemorrhage. These things are the most important in knowing that these problems can lead to high morbidity and later on mortality in the baby. Other things which can be seen in the premature baby, they are retinopathy of prematurity, sepsis, periventricular leukomalacia, and the long-term cognitive and sensory impairment. So it is said that every day the baby is staying intrauterine, there is an increase in survival of around 3%. So if the baby is daily is staying up till 38-39 weeks, every day is very important for the neurological development of the baby. Okay, then though preterm has so much morbidity, mortality, but because of few interventions like the antenatal steroid, improvement in the neonatal intensive care unit, it has raised our hopes. We are able to survive the babies. In India, we take the age of viability as 28 weeks, while in US, we take the age of viability as 20 weeks. While WHO says the age of viability is 24 weeks. So it depends upon the type of neonatal care we provide, and depending upon that, the baby will survive. Okay. Okay, if you have any queries, please write on your chat box so that or in the last, I can take all the queries. Okay. So the next thing is, what are the causes of preterm labor? Can any one of you tell me what are the causes of preterm labor? What could be the causes of preterm labor? What can lead to preterm labor? Yes, anyone? You can write on your chat box. Yeah. Okay. Someone is saying, Ishika is saying polyhydramnios, iatrogenic. Very good. Yes, preeclampsia, big size baby. IFD. What is IFD, Pushkar? IFD. Maternal infection, Jaya. Yeah. Very good. Very good. Multiple pregnancy. So we have, these are the main causes of preterm labor. Actually, it is a multifactorial things, and the important causes are intrauterine infections, cervical abnormalities, uterine malformation. They constitute the majority of the causes of the preterm labor. Now, preterm labor, usually it has been seen at around 10% of the babies are preterm out of all, and infection account for around 20 to 40%. Other thing could be the over distension of the uterus, as many students have very well said that in the cases of multiple pregnancy there is increased risk of preterm labor. But can you tell any one of you how the infection or over distension of uterus can lead to preterm labor? What happened? Why infection can lead to preterm labor? Yes. How infection can lead to preterm labor? What is it doing? Or how the over distension of uterus can lead to preterm labor? Very good. Swati is saying release of prostaglandin. Yes, very good. So the prostaglandin release is the inflammatory mediators. Pragya is saying yes, very good. Actually, what happened? The final pathway for the preterm labor is the release of these prostaglandins. Okay, so let's see. how the different mechanism can lead to preterm labor. Okay, as some of you said, in 75% of the cases it is spontaneous, but it is iatrogenic too in some conditions that require early delivery of the baby, like in cases for the maternal sake or for the baby's sake, like in cases of preeclampsia, in cases of fetal growth restriction with abnormal Doppler, in cases of maternal diabetes which is poorly controlled, or the placenta previa is bleeding, that's why we need to terminate early, or because of abruption at early gestation before 37 weeks. So in these conditions, we actually induce labor, or we actually are doing termination by cesarean section or by vaginal deliveries. So it also constitutes one of the cause of preterm labor. So as I said, let's coming on to the pathology of preterm labor. What thing, how they are doing, how infection is doing, how decidual hemorrhage is doing, how pathological uterine distension, they all lead to preterm labor. And very important thing, there is something called as preterm parturition syndrome. It has been seen that the activation of the maternal and the fetal hypothalamic pituitary axis, this can also, early activation can also lead to preterm labor. The final pathway will remain the same as you people said. It is a release of, it's an inflammatory reaction leading to upregulation of the prostaglandin, cytokine, and inflammatory mediator within the cervix, myometrium, and the fetal membrane. So this is the final pathway. But let's see one by one how it is doing. So, as I said, the first thing is activation of maternal and fetal hypothalamic pituitary axis. So, what happened if there is an increased maternal stress or fetal stress? Any kind of maternal stress. It is also said that in pregnancy, if the mother is given too much of stress in terms of physically or in terms of mentally, it can affect the baby. How it can affect? It can lead to premature rupture of the. It can lead to preterm labor. Now, what happens whenever there is increased maternal stress? It will activate the cells in the placenta and decidua and the fetal membrane. Now, these cells activation will lead to release of corticotropin releasing hormone and estrogen. Okay. Now, the CRH cause release of this corticotropin releasing hormone will lead to release of prostaglandin and estrogen, and it will activate the myometrium. Now, such activation will lead to something called as a preterm labor. So the main mechanism is the stress leading to activation of the cell in the placenta and decidua, leading to release of corticotropin releasing hormone, and the final pathway, that is release of prostaglandin. Okay. So the second thing is, as I said, infection. Infection has been seen, they can lead to spontaneous preterm labor in around 20 to 40% of the patient. Infection itself will lead to increased macrophages, neutrophils in the blood circulation. And these cells, they release various cytokines. Now, these cytokines, they lead to production of utrotonins. What are utrotonins? Like prostaglandin, leukotrienes, endothelins, and proteases. Remember, the cervix is made up of cervix ki, if you study the anatomy of the cervix, you will find that the cervix, the upper layer of the cervix contains the circular muscle fiber at the position of internal os, while the tissue of the cervix is made up of various collagens. Okay. So whenever these proteases and matrix metalloproteinases, they act on those collagen, they will destroy them and leading to rightening of the cervix, leading to shortening of the cervix, and ultimately it will open up. Okay. So these cytokines and these prostaglandin leukotrienes, they will lead to preterm labor, early opening of the cervix. Okay. So third thing is, till now we have covered the how the activation of hypothalamic pituitary axis is leading to preterm labor. Then we have covered how the infections are leading to preterm labor. Decidual hemorrhage is one of the factor, like because whenever there is an abruption or small bleed at choreo-decidual interface. Now, this will lead to generation of thrombin in between the choreo-decidual interface, and this thrombin has again action on the protease and prostaglandin production, leading to activation of the myometrium. So all these factors, they are leading to preterm labor. Similarly, as many of you said, if the uterus is over distended, like in cases of polyhydramnios, in cases of multiple pregnancy, or the uterine abnormality. Which uterine abnormality can lead to preterm labor? Like whenever the uterus is not able to expand, like in cases of unicornuate uterus or Mullerian anomalies, where the cavity is very small and it is not able to expand. So what happened? There is a pathological uterine distension, either because of the above said condition or because of some Mullerian anomalies. What will happen? It will lead to stretching of the myometrium and the fetal membrane. And whenever this stretching occur, what happens in normal labor, when the patient starts getting contraction, there will occur a pressure over the myometrium and the fetal membrane. This is actually what happened in the normal labor. Here, because of the polyhydramnios, because of multiple pregnancy, there is a existence of the persistent stretching on the myometrium and the fetal membrane, and this stretching will lead to myometrial activation and enhanced gap junction formation between the cell, and increase that will lead to increase in the oxytocin receptors and increase synthesis of prostaglandins. Okay, any problem till now? Any problem till now? So basically, exam mein aayega, so what you have to write? You will write the definition of the preterm labor, you will write the causes, and you know the pathophysiology. Final common pathway you all know, but how the different things are leading to preterm labor, that you should know. Can we predict this preterm labor? Okay, let's go back. Can we predict this preterm labor? Any one of you? Can you predict in which patient the preterm labor can occur? Yeah, can we predict? Yes, we can predict. Very good, Pragya. Previous history. Previous history और और कुछ किसी और से हम बता सकते हैं कि प्रीटर्म लेबर हो जाएगा इस पेशेंट में? अभी तो आपने बोला we identify the risk factor, especially in cases of polyhydramnios, multiple pregnancy. We know that in fact they can have preterm labor. Already we know कि multiple pregnancy है तो ये टर्म तक जाना मुश्किल होगा, या प्लेसेंटा प्रीविया है. So there are some maternal factor. Yeah, Anubha is saying cervical length. Very good. So let's see. So we can predict preterm labor. One is by the history, that is over the seeing the maternal factors. What are the maternal factors? Is she having diabetes, poorly controlled diabetes? Is she having multiple pregnancy? Okay, and is she having any Mullerian anomaly and she is conceived? Okay, so and someone said Bishop score. Bishop score, yes, clinical assessment can be done, but it is usually we don't do the clinical, we don't do a per vaginal examination and checking the cervix every time, because it can lead to ascending infection. Okay, uterine activity monitoring is a very good method. It has been found that if the mother says I am getting contraction, so it could be a predictor that later on, as she is getting more and more contraction, the cervix will ripen. So she is at threatened preterm labor stage when she is getting pain, but there are no cervical changes. That is called as threatened preterm labor. Okay. Other than that, very important thing is the ultrasound assessment. I'll show you the pics of how cervix look like in ultrasound. We can see the length of the normal cervix. So usually the length of the cervix is around 3 to 4 centimeter. Okay. Then next thing is, as I said, infection or inflammation can lead to preterm labor. Now, so we can do screening for asymptomatic bacteriuria. We can do genital tract infection screening too. Other than that, we have various biochemical markers also available for detection of the preterm labor. Ma'am, could you please repeat what is threatened? Okay, threatened preterm labor is when the patient is having pain. Preterm, matlab before 37 week, the patient is having pain, getting the contraction, but till now the cervix has not ripened, cervix has not opened. Preterm labor, when we say the patient has already gone in labor, when the contractions are associated with the changes in the cervix has opened up, then we say it is preterm labor. Okay. So the history and the risk assessment. What all in the history? Very important. Someone said prior history of preterm labor. It has been seen that prior one preterm delivery will lead to around 10 to 15% chance of having preterm delivery in the next pregnancy. Two preterm labor lead to around 40% chances that the next pregnancy would be a preterm, and prior three preterm labor, 60% chances are there that the patient will have next preterm delivery. So the prior preterm delivery history is something very important. Other than that, if the patient has come to you with the preterm prior history of preterm pre-labor rupture of membrane, last pregnancy, the patient is saying that I had leaking at 8 months of gestation, then you should be alert that this patient can have preterm labor in this pregnancy. Sorry. Other than that, if the a specific history, mid-trimester pregnancy loss, whenever we ask you what are the causes of the mid-trimester abortion, so the first thing that should come out should be the cervical incompetence. So any patient, there is some problem in the cervix is getting open up early. In those cases, mid-trimester pregnancy losses, if there is such history, this patient will be at risk of preterm delivery. Congenital uterine malformation, as we have already said, multiple pregnancy, if the patient has episode of vaginal bleeding. Vaginal bleeding could be because of anything, could be because of abruption, little bit of abruption, or if there is a placenta previa. Placenta previa, the patient usually have a warning hemorrhages, small amount of hemorrhages before the actual large hemorrhage. Okay. Short cervix on the ultrasound, or the patient is saying that in the last pregnancy, the doctor told me that my cervix is small. Usually we tell them this thing, that okay, this was the problem. Okay. Or if surgery has been done over the cervix, specifically cone biopsy, when we remove a large part of the cervix. Okay. Sometimes there is injury to the circular fibers of at the internal os that will lead to some kind of cervical incompetence. So these are the important risk factor in the history by which you can predict the preterm labor. Any questions till now? Okay, Pariniti is asking which markers. Yes, the markers I will tell you later on. We are coming one by one, first by history, then imaging, and then markers too. Okay, LETS is large loop excision of transformation zone. Jyotsna, LETS is large loop excision of transformation zone. किसमें करते हैं हम? When we are finding any CIN or cervical intraepithelial neoplasia, in that case, we do a excisional procedure, that is large loop excision of transformation zone. The area which is abnormal, we remove it. We send it for the biopsy and we'll see the margins are clear or not clear. Okay, okay, Josna. Mostly, let's, if this large loop excision of transformation zone, if the depth is more than 2 centimeter, then there are high chances of cervical incompetence. It is a cone biopsy which is more at risk, because we remove a cone of the cervix, and sometimes while removing a cone of the cervix, we do injure the internal os. Okay, so let's go ahead. As I said, one is by history, second is by doing a scan. Ultrasound, can you see this is the ultrasound picture? And ultrasound, whenever we are doing, always remember the best ultrasound type by which we can see the cervix is you will ask the patient to empty the bladder and you will use a transvaginal probe. Transvaginal probe has high sensitivity for calculating the length of the cervix rather than transabdominal, because the probe will be near to the cervix. That's why. Okay. So you can see this is the probe. So this is anterior, this is posterior. These are the baby part. This is the liquor, and this is the cervix. So this is the internal os. This is the external os. You can measure this length. Normally, in a normal woman, this cervix will be around 3 to 4 centimeter. We calculate it from internal os to external os. But see here, what you can see, that the amniotic fluid is coming into the cervical canal. This is amniotic fluid coming in the cervical canal, ultimately leading to the length of cervix is only this much left. Okay, small, the length of this is called as this opening of cervix will lead to funneling of the cervix. This is called funneling of the cervix, and this is now the functional internal os, and this is the external os. The length is very less. So many guidelines say that the cutoff of less than 1.5 centimeter is used for the diagnosis of the preterm. Remember, I'm saying something. I'm saying that when we screen any patient for cervical length assessment, तो हम screening कब करते हैं? हम करते हैं at 20 week, 24 week. उस टाइम पर हम बोलते हैं कि if the cervical length is less than 2.5 centimeter, then it is a positive screening test. The patient can go in labor. तो हम patient को start करते हैं with some intervention like progesterone. Okay. But if a patient has come to you with contractions, she's getting pain, and on you do an ultrasound, and if it is less than 1.5 centimeter, that means the patient is already in established preterm labor. Okay, so here we are talking about the diagnosis, not the screening. That's why I said the cutoff of 1.5 centimeter and not 2.5. Screening may we take 2.5 centimeter as a cutoff for predicting the patient can have preterm labor. Understood? Okay, someone was asking, ma'am, what are the various marker of preterm labor? यहाँ पर हमारे पास क्या होता है? I will tell you that we have some tests which are very well studied in various institutions. Various research have been done. One of this test is fetal fibronectin test. Okay, someone is asking, ma'am, what is funneling? Jyotsna, funneling is देखो, funneling is when the cervix, just a second, let me just show you again. Just a second. हाँ, देखो यहाँ पर क्या था बेटा, यहाँ पर जो इंटरनल ऑस क्लोज था, जब इंटरनल ऑस ओपन होना स्टार्ट हो जाएगा तो हम क्या होगा, when this will open up, now there will be a funnel. What is a funnel? Funnel is like an open up structure and followed by the stem. Similarly, now the cervix is opening up, there is a formation of funnel like thing, and the stem is very small. This is funneling. As we say that initially what will happen in the books, you will find there is a formation of BU formation. Initially it will start opening up, then it will open up more, it will lead to formation of a U shape like structure. Okay, so this is called as funneling, when there is a opening of the internal os leading to shortening of the length of the cervix. Fine, Jyotsna? Okay. So coming on to this test, in preterm labor, it is a fetal fibronectin test, which is very, it is something which is tested quite frequently, and it has good sensitivity and specificity. So what is this fetal fibronectin? Basically, it is a glycoprotein which is found in high concentration in cervicovaginal secretion. before the fusion of membrane. So uh, um, fusion of the membrane which occur at around 21 week of gestation. So this glycoprotein is found in very high concentration in cervicovaginal fluid. Basically, you remember this thing. It's a glycoprotein found in cervicovaginal secretions. Okay. Now, what happens whenever there is a disruption of choriodecidual interface? Because of some reason, there is a disruption of choriodecidual interface after 21 week of gestation, like because of inflammation or because of trauma, that will lead to secretion of fetal fibronectin in cervix and vagina. So in simple term, if I'll tell you what is fetal fibronectin, basically whenever because of anything, as we said the 3-4 factor, as we said there is a ultimate pathway is the release of prostaglandin and all that. Whenever such thing happen, some activation of the myometrium happen or the cervix happen, the release of this fetal fibronectin increases. So what we can do, we can take a swab either from the posterior fornix or from the ectocervix, and we can detect this fetal fibronectin. Okay. Now this can predict, it can be used for predicting the preterm labor between 22 to 34 week of gestation. Okay. So this test, if you find that fetal fibronectin is more than 50 nanogram per ml, it is a sensitivity of around 67% and specificity of around 81% in predicting, in diagnosing the preterm labor. Everyone clear with the fetal fibronectin? Simple terms, ऐसे याद रखना है कि क्या होता है, बस ये याद रखो कि whenever there is activation of the myometrium or the cervix, the fetal fibronectin release will increase, and we can detect this glycoprotein by ELISA. And this is done. Why between 22 and 34? Why not before 22 week? Why not after 34 week? Why we are using it between these two gestation? 22 weeks से so before 22 week the viability is very less. There is asking, is it done in our hospital? Yes, it used to be done in our hospital by some organization as a project work 2-3 years back. But nowadays, we don't have the kit at present. But it can be done. This kit is available in private, like the patient can buy and then we can do. Actually, it's a costly test, and these are not generally available. But as per requirement, we can ask for it and we can do it. Okay. Yes, before 22 week, one thing is the levels would be high, and secondly the viability is very less. What we will diagnose, what we will do if I detect the high fibronectin level and the patient has already gone in labor, the baby will not survive and the levels will be high even physiologically, as I said. Yes. So we go ahead, other marker, we will see the other markers. Before going ahead, the contraindication, as I said, more than 34 week we don't do, because the fetal lung maturity has already been achieved, and it will depend upon the benefit risk ratio. Actually, there is no risk. The risk is the cost effectiveness. Okay, after 34 week, the baby, most of the babies, they do survive because of the lung maturity is there. If there's a rupture of membrane, the liquor will come out, and then it is not to be done. In multiple pregnancy, if the cervical length is more than 3 centimeter, we are not like on ultrasound, if I can see that the cervix length is adequate, so we should not go for this test. Okay. If there is a vaginal bleeding, that will change the fluid of the cervix in the vagina, it will not be diagnosed it correctly. And if there's some vaginal examination has been done, you have used lignocaine jelly, or the patient has a history of intercourse the prior 24 hour, or any kind of gel you have used, then it will not be that reliable. Okay, so this thing should not be done in these conditions. Other biochemical marker are insulin like growth factor binding protein 1. ये जो markers हैं, they can come in your MCQs. ठीक है, preterm labor के अंदर what are the various markers? Though these markers are not very reliable, the studies are still going on, but they can come as an MCQ. So the insulin like growth factor binding protein 1, interleukin 6, we can, because they are basically the cytokines, we can detect these cytokines and then diagnose preterm labor, closing factor alpha. Okay, any problem till now? How we are detecting preterm labor? By history, examination, per speculum examination we can check, but per vaginal examination generally not done because it will increase the risk of infection. Per speculum, whenever we are doing per speculum examination, we can see the length of the cervix, we can look for any infection which is there in the vagina, because we can treat that infection. Okay, we can do an ultrasound and we can do some biochemical test. Fine, should I go ahead? Yes, should I go ahead? Management, should I cover the management? Yes, please write something on the chat box so that I can go ahead, you can hear me. Okay, okay, fine. So management of preterm labor, any patient has come to you at 34 week of gestation with the problem of preterm labor, she is getting pain. So what are the various how you are going to manage that patient? First thing is, the patient has come with a preterm pre-labor rupture of membrane. That is a separate topic, I'll teach you in detail. But let's see other things, like what is the role of tocolysis? What is tocolysis? What is tocolysis? You must be knowing tocolysis is toco. Toco is contraction. Lysis is stoppage of contraction. So uterine relaxant. What is the role of uterine relaxant? In which condition we should give relaxant? What are the various tocolytics available? What are the antibiotic which is available? Steroid. Magnesium sulfate for neuroprotection. What is the role of magnesium sulfate? Very important thing. And what is the mode of what should be the mode of delivery? Okay, so in the management, these are the 3-4 things. Exam mein aayega kisi bhi patient mein, whenever you are doing a preterm delivery, remember these 2-3 things. Okay, I will tell you antibiotic has no role. It is a steroid which has a role, and in which condition you are giving neuroprotection by magnesium sulfate. Okay, let's go ahead. Tocolysis. It can be considered. Remember, role of tocolysis is only for the short term use. ठीक है, कब यूज कर सकते हैं टोकोलिसिस? ऐसा नहीं है कि आपने प्रिडिक्ट कर लिया कि पेशेंट को प्रीटर्म लेबर होगा और आप पेशेंट को 24 या 28 वीक से 34 वीक तक आप टोकोलिसिस पे रखोगे. यू कैन नॉट डू दैट. Currently, the role of tocolysis is only for a short term, that is when you are completing the course of corticosteroid or you are transferring the baby to some higher center for the good neonatal care. Okay, the various drugs which are available for the tocolysis, you can study them in detail in your books. One is atoxapen, oxytocin receptor antagonist, not available in India. Yes, it is do available in private because it is costly, and in UK it is the only drug which is available. In India we have nifedipine. Remember this drug nifedipine, which is given 30 milligram stat followed by 10 milligram TDS. And as I said, this tocolysis you will give when you are waiting for the steroid cover. Okay? Other drug very frequently used is isoxsuprine. In private practice they use it at every gestation, but it is the misuse should not be done. The other drug is magnesium sulfate, just to complete the list. Magnesium sulfate can also lead to it will relax the uterus. ठीक है. But they have various problem, like whenever you start nifedipine, you should monitor the patient. Monitor the patient because these can lead to, there are chances of tachycardia. There are chances of isoxaprine, very commonly it is associated with tachycardia, and you should monitor the pulse rate of the patient. If the pulse is going beyond 120, you should stop it. Okay. And it can even lead to the various side effects, like it can lead to pulmonary edema. Role of antibiotic in a simple preterm labor, when the membrane are intact, it should not be recommended. No antibiotic cannot, now when the patient has already gone in labor, the antibiotic will not prevent anything. Okay. So generally, if any patient come to us at 34 week of gestation, she is already in labor, there's no need of starting antibiotics. If there is some obvious cause like the rupture of membrane is there, or anything, any other source of infection is there, then only we will start the antibiotic. Otherwise, in a preterm labor, there is no rule. Steroid, it is something very important. In the exam, whenever you find you are writing the management of IUGR, whom you are delivering early, or you are writing the management of eclampsia, you are managing pre-eclampsia, we want you to say that give the steroid cover. Okay. Now, what are the benefits? As I said, you must remember these three things: respiratory distress syndrome, necrotizing enterocolitis, I have not written here, and the intraventricular hemorrhage. What three things? Steroid can lead to reduction in fetal morbidity and mortality by reducing respiratory distress syndrome, intraventricular hemorrhage, and necrotizing enterocolitis. I have not written here necrotizing enterocolitis, but it is there. So these three things can be prevented by giving steroid. Okay. Steroid we generally give from 24 to 34 week, but it can be considered up to 36 week. You can give. Various Americans say that it has to be given up till 34 week, while in UK they say you can give it up to 36 week. It can be considered. Now, in which condition you will not give steroid? When the patient has already some frank infection, already in sepsis. In those patients, you may not give. Like if the patient has tuberculosis, it will exacerbate that particular infection. The most common drug. Can you tell me the two steroids which we use in obstetrics and gynae? Yes, please write on the chat box. I've written one. Okay, Purva, in between the Purva is asking, Purva, why steroid in preeclampsia? Like preeclampsia, if uncontrolled before 34 week and we want to deliver early, then yes, we give steroid. Okay, before 34 week. Yeah, most of you are right. You have written Dexa and betamethasone. So which one is better? Which one is better? You all know these are the two drugs. Which one is better? Betamethasone. Very good. Why? Can you tell me why? Why betamethasone is better? Because it has been seen in various studies that betamethasone is associated with, no, it is we are not talking about this thing. Betamethasone, when the various studies have been done, and it has shown that betamethasone is associated with less chances of periventricular leukomalacia, okay, and respiratory distress syndrome as compared to the patient whom we have given dexamethasone. The dose you should know: for the betamethasone, it is 12 milligram, 24 hour apart, two doses. Okay, so total is 24. Remember, in dexamethasone it is 6 milligram, 12 hourly, 4 doses. The total is also 24 milligram. Okay, so and remember thing, optimal benefit, ये जो steroid window होती है, if I start the steroid now, the best time to deliver the baby is from 24 hour of the last dose to the next 7 days. इस टाइम में मैक्सिमम बेनिफिट हमें स्टेरॉइड का मिलता है. आपने लास्ट डोज दी और इमीडिएटली बेबी डिलीवर हो गया, yes, there will be some benefit, but that will not be that much which could have been provided by steroid. Okay, so the last dose, 24 hours of the last dose to the 7 days. Fine. Should I move ahead? Magnesium sulfate, matlab around 5-6 years back we were not told about this thing, magnesium sulfate as neuroprotectant, but now it is there, and there are various studies which have proved the patient who are given this mag-sulf, it can lead to it will decrease the risk of cerebral palsy in the children and a reduction in the rate of substantial gross motor dysfunctions in preterm. Okay, and it has to be given shortly before the delivery. If you think the patient is in labor, then you can start. What is gestation? In generally we say less than 32 weeks you should give Magsulf. After 32 weeks we don't give Magsulf. For neuroprotection, it can be given before 32 weeks, but suppose if it's a preterm labor, then up to 29 week. Sorry, for preterm rupture of membrane, PPROM. In that, we generally give it before 30 weeks, not more than that. But in a preterm labor, before 32 weeks, you can give a Magsulf. Okay, the dose is okay. Harsh is asking one question. Mehak is saying what will happen after 7 days of steroid? But after 7 days, wo jo maximal steroid ka, that will reduce. Okay, that will not matlab the steroid ka jo last dose हुए 7 days हो गए हैं, तो it will be not that beneficial. Okay, the optimal benefit is between 7 days, but it is not so ki we will consider that we have given steroid. We will consider it has some effect, but not that much. Harsh is asking, ma'am, if we have given steroid for the lung maturity, won't lungs stay mature even after? Yes, very good. Yes, lungs will stay, but simultaneously the growth of the baby is already occurring, and the affectant and everything, that effect of the steroid will decrease, and there are chances of having some problem. But yes, we consider it as steroid covered, but the maximal benefit is between 7 days. Yeah. So the dose of Magsulf को हमने कहाँ पढ़ा था? प्री-एक्लैम्शिया में. प्री-एक्लैम्शिया में जो डोज होते हैं ना, सेम रेजिम है कि 4 ग्राम लोडिंग देते हैं यहाँ पर हम IV स्लो ओवर 30 मिनट्स. उसके बाद हम यहाँ पर इन्फ्यूजन चलाते हैं. Infusion at a rate of 1 gram per hour for 24 hours or till delivery. Okay. So the next thing is mode of delivery. Is it so कि preterm है तो we should deliver by cesarean section? No, the case has to be individualized. We should see there should be no contraindication for vaginal delivery. If there is no contraindication, go for a vaginal delivery. But if there is some obstetrical indication, you can go for a cesarean section. But remember, cesarean section prophylactically it should not be done just for the prematurity. What will happen? The lower segment is not well formed. We are doing cesarean section in the lower segment. So क्या होगा? It will be kind of classical cesarean section. So जब भी हमारे पास patient आता है with a history of prior preterm cesarean section, so our antenna should go up, and we should know that this scar can give way anytime. Okay, in that we can go ahead with the cesarean section in the next pregnancy. So it is very important. In a vaginal delivery, prophylactic forceps use or elective episiotomy is not recommended. We used to say that in a premature baby, if you are finding some obstruction, you can give episiotomy, but otherwise, if everything is fine, small baby is there coming out easily, so you need not to give elective episiotomy or forceps. But if there is like fetal distress and you need to put some instrumental delivery करनी है, तो क्या prefer करोगे? Forceps या vacuum? It is forceps, because forceps उसको एक cage देता है. It gives a complete protection, while a vacuum should not be used because the scalp is very soft. The intracranial tissue will come out. There will be herniation of the intracranial tissue. Okay, so in a preterm baby, if you need to apply forceps, if you need to apply any instrument, so go for forceps and not for vacuum. Okay, delayed cord clamping has to be done as we do it for everyone. The next thing is, if you're fine, I can go ahead with the PROM. Just a second. Preterm pre-labor rupture of membrane. Very shortly, we have already understood what is premature. Premature is before 37 week. Pre-labor is before the onset of labor. So this is a term before the rupture of membrane, before the onset of labor. It's called pre-labor rupture of membrane. Before preterm, we will say PPROM. That is preterm premature pre-labor rupture of membrane. The causes, as I said, how infection can lead to such problem. Actually, what infection does, infection will lead to increased friability of the membrane. It will decrease the tensile strength of the membrane. And some condition like polyhydramnios, cervical incompetence, putting pressure over the membranes will lead to early rupture of the membrane. It has also been seen in the multiple pregnancy. Infections like chorioamnitis, if the cervical length is less, if the patient is already in the preterm labor, it can lead to preterm premature rupture of membrane causes. Okay? Next thing, diagnosis. Diagnosis, the history, how you can diagnose. बहुत simple होता है. If the patient saying, if the patient is giving history of leaking, leaking is sudden release of gush of fluid per vagina. The patient will typically say, I spoiled all my clothes. It was a watery like fluid that has come out. And how you can diagnose it? By doing a per speculum examination. If you are doing a per speculum examination, ask the patient to cough, and if you can see the liquor, this is the best diagnostic way. Okay. Other than that, what else you can find? If the liquor has already released, the height of the uterus will reduce, and if you'll do an ultrasound, you will find that the liquor is less. Okay. Various tests have been used to diagnose this condition, like nitrazine test, Fern test. I'll tell you what these tests are. And pervaginal examination should be avoided in PPROM. Why we are not doing pervaginal examination? Because pervaginal examination will lead to there are chances of ascending infection. That's why we don't do it. These tests, nitrazine test, Fern test, we used to tell everyone, but now they are not very famous in the sense that but still you should know what is this nitrazine test. Nitrazine test is basically pH indicator. The pH of amniotic fluid is alkaline. Okay, while the normal pH of cervical fluid, it is acidic. So if you will put the swab, or if you'll take the drop of that fluid and you will put it on the nitrazine paper, and if you'll find it is coming as a alkali, or the pH is more than 6, it means that the liquor membrane have ruptured. Okay, it can come positive in cases if it is mixed, discharge is mixed with blood, or the patient has done recent intercourse. फन टेस्ट हम कहाँ पढ़ते हैं? हम पढ़ते हैं टेस्ट ऑफ ओवुलेशन में. So fern test, if the specimen of cervical mucus is allowed to dry on a slide, and there could be a ferning pattern. Okay, but if the amniotic fluid is there, the fern pattern will go. Okay, but the important thing is this new test. इसको हम this comes in the name of actin PROM. Actin PROM. Okay, basically what we diagnose, this insulin like growth factor binding protein 1. These antibodies you can find, will put a swab in the vagina, in the basically ectocervix, and we take that fluid in a tube and we'll put this strip, and this strip will detect this IGF-BP1. Okay, and it is very it is quite sensitive. The sensitivity of this test is more than 80%. So if you have some doubt, तो किस में करना है? ये सभी में नहीं करना. जिस पेशेंट में हमें लग रहा है, पेशेंट इज गिविंग हिस्ट्री कि आई हैड a gush of watery color, watery discharge, but on speculum you have done a speculum examination, no fluid is visible, you are still not sure whether it was PROM or not, then in that case you can go for these tests. Okay. PROM, ACTIM, PROM. This is basically a brand name, but what you should know that we are detecting these two things: IGF BP1 and placenta alpha microglobulin 1 in the vaginal fluid. Okay. So the next thing is investigation. Whenever any patient with a preterm rupture of membrane, तो क्या हो सकता है, problem क्या हो सकती है, infection हो सकता है. So we'll do a complete blood count. We will do a CRP. Complete blood count में always remember the TLC could be high क्योंकि आप steroid दे रहे होते हो. तो initially the TLC will reach maximum on third day of steroid. After third day of steroid. So always check CRP. CRP is very effective. Other than that, we want to know the cause of PPROM. We want to rule out the infection. So get a urine test done, culture sensitivity. Get a high vaginal swab done for gram staining and culture, and you can get a scan done for checking what is the amount of liquor, how is the baby, and we can go for CTG after 32 weeks. Okay. So what could be the complication? What complication if the patient has already ruptured the membrane before 34 week? What could be the problem? Maternal problem क्या होगी? Patient will go in preterm labor. Infection होने की chances रहेंगे. Chorioamnitis, delivery के बाद puerperal sepsis. So in a patient of PT PROM, we give them antibiotic after delivery for around 5 days. Okay. And suddenly, because the baby was very small, membrane have ruptured, there are chances of cord prolapse, chances of placental abruption, and if there is no like around the baby, the chances of dry labor and chances of fetal distress, they are quite high. So baby mein kya hoga? Baby is delivering early. There are chances of amniotic fluid is required for the complete lung expansion. If there is no liquor, there are chances of pulmonary hypoplasia. There are chances of neonatal sepsis if the mother is having sepsis, and because of prematurity, chances of respiratory distress syndrome, and there are high chances of morbidity in terms of cerebral palsy. Okay, fine. General treatment. So the treatment is what you will do if the patient has come with the PT PROM. Admit the patient, give them the bed rest, uh, ask them to wear a sterile verbal pad, give broad spectrum antibiotic. The antibiotic we give is erythromycin 250 milligram QID for 10 days. Erythromycin 250 milligram QID for 10 days. Remember, we should not give augmentin. Augmentin is amoxiclav. It has been seen if you give amoxiclav, there are high chances of necrotizing enterocolitis in the baby. Okay, so antibiotic is given in PT PROM. We'll consult the mother. We can do the maternal monitoring. Daily we will come and we will check her temperature, pulse, BP. We'll see her pad. The pad should be looked for any bad odor, any uterine tenderness, because bad odor, increased temperature, increased pulse, it could be sign of chorioamnitis. Okay, and the fetal monitoring, FHR 4-hourly, or we can do fetal heart, we can check by stethoscope. CTG we can do daily, and biophysical profile weekly. So if a patient has come with chorioamnitis with PROM, so chorioamnitis मतलब infection. Now baby के लिए it is a bad environment. Terminate the pregnancy. Okay. Best would be doing a vaginal delivery, and if there is some contraindication for vaginal delivery, then do a cesarean section. However, it will be a preterm cesarean section. So first go for vaginal delivery. Remember this thing. But if there is a chorioamnitis, patient is deteriorating, you can go for a cesarean section also. Now, this is very important. This slide is very important. If the patient has come to you with pre-labor rupture of membrane without chorioamnitis, there are no sign of infection. So जब 37 week के बाद leaking करके आएगी तो क्या करना है? हम 24 hour के लिए we can leave the patient for expectant management, because it has been seen around 70% will go in labor within 24 hours. And if already patient कह रही है कि मुझे 2 days से I am having leaking, then go for induction of labor if there are no contraindication for cesarean section. Okay. between 34 to 37 week, can go ahead with expectant management. What is expectant management? We're not doing anything. Daily you are monitoring the mother, you are checking her temperature, pulse, seeing the baby fetal heart, checking her pad कि कोई sign of infection तो नहीं है, sending the investigation, okay, giving antibiotic. Now 24 to, the important thing is 24 to 34 week. In this time we give what we studied in the preterm labor. We give antibiotic, erythromycin. We give steroid cover because the baby is less than 34 week. We give neuroprotection. Neuroprotection has to be given up to 30 week in preterm PROM. In utero transfer can be done if the baby is very small. We can send the baby to a higher nursery, any center with better nursery care. And less than 24 week, active termination of pregnancy should be done because baby may not survive well. We have already closed the time. I'll just finish in 1 or 2 minutes. Okay, someone is asking dose of erythromycin 250 milligram, tab 250 milligram QID for 10 days. Corticosteroid, I have already explained you the role of corticosteroid should be given before 34 week or can be given up to 36 week. Tocolysis, membrane already ruptured, not recommended. Magsulf, as I said, can be given up to 30 week in PT-PROM. Otherwise, we can give it before 32 week. Okay. Any queries? Any queries? Yeah. Any queries in the preterm labor, PT-PROM? Can steroid be given again after? Okay, that's a very good question. Can we repeat the steroid? मेरे पास patient 31 week पे preterm PROM करके आई थी. अब patient 33 week हो गई है, अब labor में जा रही है. Should I give steroid or not? So steroid का हम ये कहते हैं कि it should not be given again and again. But yes, if you have given one dose of steroid before 26 week, then you can give another dose of steroid. That is called as a rescue dose of steroid. Okay. Is asking, please repeat mag sulfate. Magnesium sulfate is a neuroprotectant. Okay, it can be given before 32 week if the patient is going in labor. If the patient has come with PT-PROM, it can be given before 30 week of gestation. If the baby is less than 30 week of gestation in a PT-PROM and in a preterm labor less than 32 week of gestation, you can give Magsulf. How the Magsulf is to be given? It has to be given 4 gram IV loading dose followed by 1 gram per hour infusion for 24 hours. Role of ampicillin, beta ampicillin की बजाय we give erythromycin. We prefer giving erythromycin. We are not giving amoxicillin because there is a risk of necrotizing enterocolitis. You can give ampicillin. Sometimes hive channel swab is saying is showing sensitivity to ampicillin. Yes, you can give ampicillin, but mostly we prefer erythromycin. Yeah, Ishika is asking, ma'am, post-datism is after 40 weeks, post-term is after 42 weeks. Any more questions? I've already taken your time. It is 9:07. Yeah. If all things are fine, I can close the session. Okay, thank you so much. How to stop?